To all, I am Vishnu. So this is episode 2 and this is my 37th video in my YouTube channel. So I am continuing the same series as I said before, amazing facts about medications. So it can be related to pharmacology, it can be related to therapeutics, but whatever is special about any medication or any system in our body, any 5 aspects. It can be any 5 aspects. It can be any 5 medications. It can be maybe a system of our body. Anything it can be, but something that is very catchy that I will be sharing in short slides on a daily basis. So let's go into episode 2. So episode 1, you can refer my past video. There I've talked about SSRIs, why they cause sexual dysfunction, why they cause diarrhea as a side effect, what are the interesting aspects of levodopa, why do anticholinergics cause fever as a side effect, and why amiodarone causes both hypo and hyperthyroidism. So all these things I explained there. So today I'll be explaining 5 other things. So as I said, this thing I had said in the previous presentation also, if you are a person who is struggling with getting practical skills or practical knowledge, you have 2 options. Either practically see, that means you are a professional, you go to the hospital and do your duty, you see things. Or if you are a student who is going for hospital duty, then you go to the hospital, see cases, and you learn a lot of things in the process. But in many areas, I know that many of you are not getting proper hospital exposure. It doesn't mean that you should not know anything. In that case, the next thing that you can do is practically visualize. So that is actually something that I try to target more. So actually the benefit of practically visualizing is that you can correlate a lot of things together. So I have given some examples here. This I had explained in the previous presentation also. So this will be my, uh, scope or introduction in every video that I will be sharing under this episode series. So let's come to the speciality of mannitol. So mannitol, you know very well, it is a very, very weak diuretic. It is also known as osmotic diuretic. We have other osmotic diuretics also. We have glycerin, we have isosorbide. So mannitol is an osmotic diuretic. So if mannitol is given, what is its function? So its function is it removes water from tissues. That is the function of mannitol. Mannitol removes water from tissues, which is good for cerebral edema. So it is, you have understood from the term very well. And also in acute congestive glaucoma. Congestive glaucoma means fluid fill in front of the eyes, and means it's a very serious stage where you're not able to see anything. It's totally blurred. There, IV mannitol can be of help because it helps in removing the water from tissues. But that is another problem as well. If mannitol removes water from tissues, the water will arrive at plasma because whatever you are taking from the tissue, it will directly go into the plasma. And if water arrives at plasma, already the plasma has a particular volume. When extra water is coming into the plasma, it causes expansion of plasma volume. That increases pressure on the heart. So that increases the risk of pulmonary edema as well. Already you know very well in heart failure patients, there is something called preload and afterload. And also in most of the heart failure patients, we also see pulmonary edema very commonly. So that is why mannitol is contraindicated in patients with congestive heart failure or pulmonary edema. Why congestive heart failure? Because when there is plasma volume expansion, it increases the load on the heart. And what do you mean by heart failure? Heart failure is a condition in which the heart is not able to function properly on its own. So if you are giving more pressure on the heart, which is already weak, it will further break down the heart. So that is why mannitol should be avoided in CHF and definitely in pulmonary edema as well. So this is something interesting about mannitol. To remember the name of the drugs that cause hypercalcemia as a side effect, that is increased calcium level in the blood, you can remember the mnemonic VALPROATE. So actually, these are not the only drugs that cause hypercalcemia. There are a lot others also. I just made a mnemonic of my own and I'm sharing it with you. V stands for vitamin A or D intoxication. This is very interesting. Usually we study that vitamin D and calcium are best friends. In the treatment of osteoporosis, we usually say that if a patient is suffering from osteoporosis, you should not take only calcium, you should take vitamin D also. Both should complement each other. But vitamin A intoxication also causes hypercalcemia. There is another interesting aspect with vitamin A. If you are overdosing on vitamin A or if your body is in excess of vitamin A, it can damage the liver also. You can refer drug-induced liver disorders. In that, you will find vitamin A. You can refer it on your own. So vitamin A intoxication also causes hypercalcemia. Aluminium intoxication also causes hypercalcemia. Now, how will aluminium get inside your body? So if you are taking any antacids, which contains aluminium, because aluminium is usually aluminium hydroxide, magnesium aluminium complex antacids are there. So if you are overdosing on aluminium, that can also cause hypercalcemia. Lithium also causes hypercalcemia. Lithium, you know very well, it is a medication that requires therapeutic drug monitoring. It's a very dangerous medication. It is usually used in the treatment of bipolar disorder or mania. And lithium has a very special property also. It actually blocks an enzyme known as glycogen synthase kinase type 3, GSK3. Actually, there is a protein in our brain which is known as BDNF, brain-derived neurotropic factor. So that is very important in the upregulation. Upregulation means increased level of serotonin and norepinephrine. And these are very good for improving our mood. So if the level of BDNF reduces, serotonin and norepinephrine will also reduce. That can lead to depression. And BDNF reduces due to an enzyme known as glycogen synthase kinase 3. So lithium on long-term therapy also blocks glycogen synthase kinase. And that is why lithium may be a good option in the long term for a patient suffering from depression. But we do not directly give lithium for depression. As I said before, it is a drug that requires therapeutic drug monitoring. The side effects are very, very severe. Then we come to estrogen. So estrogen also increases the level of calcium. Please remember, if you are a person who is studying in second year PharmD, or if you are a person who is dealing with orthopedic disorders, you should always remember that estrogen is the best friend of calcium. Estrogen actually helps in the reabsorption of calcium from the intestines. And that is exactly the reason why once a female enters her menopause, that is after the age of 45 to 50, the female will have a high risk of osteoporotic fractures because after menopause, estrogen will not be there. So there is no protective effect on calcium. So calcium will get eliminated. So calcium level will get reduced. So the bones will become very weak. And if that female falls down, she can get fractures very easily. So that is also another reason why females usually take hormone replacement therapy after their menopause. This is also another reason. But keeping that aside, estrogen increases calcium level in the blood, and estrogen has its own side effects also. It increases the risk of breast cancer. So if a female during her normal menstrual life, if she had breast cancer, then after menopause, she should never go for hormone replacement therapy. And estrogen also increases the risk of ovarian carcinoma, and other lot of other issues are also there with estrogen. I'll come to that later. I was just talking in correlation with a lot of things. So yeah. Next, we come to thiazides. So thiazides are usually diuretics, which are usually the drug of choice in the treatment of hypertension. Because they are cost effective as well. You can refer my video on thiazide diuretics. We'll get all the details from there. Tamoxifen is actually a estrogen receptor modulator. So this is usually used in the treatment of breast cancer. So we have raloxifene, we have tamoxifen. So these are usually used in the treatment of breast cancer. And then we have theophylline. So theophylline also increases calcium level. Theophylline is actually a bronchodilator. It's a phosphodiesterase inhibitor. There is a very special effect of theophylline, and that is it has diuretic effect. Please remember, theophylline has diuretic effect. And that is why if you are taking theophylline at night time, and also if you are a geriatric, it will not be a very good option, because usually geriatrics have trouble in sleeping. And if you are taking theophylline or theophylline derivatives at night time, due to its diuretic property, the geriatric will tend to lose his or her sleep due to frequent urinating urges in the middle of the sleep. So that is why that is something that we need to take into consideration. The reason why theophylline actually increases urination or has diuretic effect is because theophylline is actually a caffeine derivative. And you know very well that when you drink coffee, you usually have a tendency to urinate because caffeine increases urine output. So theophylline has a diuretic effect. Drugs that cause hypokalemia as a side effect. So that means reduced potassium. Beta 2 agonist. So beta 2 agonist, like for example, salbutamol, or it can be formoterol, indacaterol, etc., etc. So these are usually used in the treatment of asthma COPD. They have a tendency to cause hypokalemia. Alpha blockers also cause hypokalemia as a side effect. So that is also one thing that you need to know. Insulin also causes hypokalemia. So insulin and potassium are actually enemies. So when insulin reduces, potassium increases, and vice versa. Theophylline or caffeine also cause hypokalemia. And this is interesting. Vitamin B12 or folic acid can also reduce potassium level in your body. Amphotericin B is actually an antifungal medication. This is not usually used. We usually use it only for severe fungal infections, like you are having cryptococcal infections or maybe severe aspergillosis or something like that. Only then we go for it. Otherwise, we usually go for lower antifungals like azole antifungals and all. So amphotericin B can also cause hypokalemia. Penicillins can cause the same. Fludrocortisone. Fludrocortisone is actually given for severe hypotension. So it is a mineralocorticoid. Actually, it's a mineralocorticoid. The naturally occurring mineralocorticoid in your body is aldosterone. But in a medication form, we do not give aldosterone. So what do we give? We give fludrocortisone. And then we have diuretics that can cause hypokalemia. Loop diuretics are notorious for causing hypokalemia. Others also cause, but loop diuretics have the highest risk. Except potassium sparing diuretics. Actually, when you look at the classification of diuretics, we have potassium sparing diuretics also. So potassium sparing have the least risk of causing hypokalemia, because potassium sparing means it is preventing the elimination of potassium through urine. Let's talk about carbonic anhydrase inhibitors. So these are actually, for example, acetazolamide, dorzolamide, brinzolamide, methazolamide, etc., etc. So carbonic anhydrase enzyme, carbonic anhydrase inhibitors, they block the enzyme known as carbonic anhydrase. So when this enzyme is blocked, what happens is bicarbonate is eliminated through urine. And bicarbonate, you know very well, it is basic in nature. So when bicarbonate is eliminated in urine, it reduces the pH of the blood. Always remember, when bicarbonate is eliminated from the body, the pH of the blood reduces. So that is a condition known as metabolic acidosis. That is why you can correlate this with a practical knowledge, like in CKD patients. In CKD patients, the normal function of the kidney is to maintain the pH, which is 7.35 to 7.45. When the kidney is damaged, the pH gets reduced. That is why in the treatment of metabolic acidosis, we give sodium bicarbonate, because bicarbonate helps to maintain the pH. So here, when carbonic anhydrase is blocked, bicarbonate will get eliminated from the body, which will reduce the pH. So the side effect is metabolic acidosis, but the same side effect can actually be used for another condition that is called metabolic alkalosis. So if a drug causes metabolic acidosis, you can use it for metabolic alkalosis. So usually other diuretics cause metabolic alkalosis as a side effect. In that condition, we may give carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors, they block the enzyme carbonic anhydrase. So they reduce the pH of the CSF also. As I said, they cause metabolic acidosis. So they reduce the pH of the CSF, that is cerebrospinal fluid also. So when the pH of the cerebrospinal fluid is reduced, it activates medullary ventilation center. Always remember this. Medullary means related to the medulla oblongata. And you know the function of medulla oblongata. It is to regulate your respiration, and it is also to regulate your heart rate. So when medullary ventilation center is activated, it will increase your breathing tendency. So this is actually good for mountain sickness. That is why whenever people go in high altitudes, like for example, you are going for trekking or you are going for any mountaineering trips or something, usually as the altitude increases, the level of oxygen reduces. When the level of oxygen reduces, you have a tendency to feel sleepy, nausea, vomiting tendencies and all come. In that condition, usually acetazolamide is a very good option because it reduces the pH of the CSF, as a result of which medulla oblongata is activated. It will activate your respiratory drive or your tendency to breathe. So it is good for mountain sickness. The same mechanism is also good for sleep apnea. If you want to know what is sleep apnea, you can refer my video. I have already explained about sleep disorders. In that, I have talked about obstructive sleep apnea. So sleep apnea is a condition in which you suddenly lose your tendency to breathe. So this is a very dangerous condition. So if you suddenly lose your tendency to breathe, you may get up in the middle of the night totally breathless. So that is very dangerous, especially if you are a person who is very obese. This risk factor can be dangerous. So in that condition also, we can give carbonic anhydrase inhibitors because they reduce the pH of the CSF, activating the medulla oblongata, and that can increase your tendency to breathe. Carbonic anhydrase inhibitors also increase the excretion of potassium. That means they can cause hypokalemia as a side effect. But it is because of this hypokalemic property, it is used for another condition, which is known as familial hyperkalemic periodic paralysis. So this is actually a paralytic condition in which this is actually a genetic condition in which the level of potassium consistently is on a elevated mode, or it is in a high level. So in that condition, we can give carbonic anhydrase inhibitors because they facilitate the excretion of potassium from the body. Now we come to the last aspect, that is the drug interaction of valproic acid. This is just one interaction that I have mentioned here. So when you take valproic acid, it undergoes metabolism into 2-propyl-4-pentanoic acid. So that is the compound. And this compound is responsible for hepatotoxicity. Please remember, valproic acid can cause pancreatitis also. But the risk of pancreatitis is more if it is used in children below the age of 2 to 3 years. In normal age, it can cause, especially if you already have some pancreas related problem. But valproic acid is hepatotoxic in nature because of the metabolite 2-propyl-4-pentanoic acid. So this toxic metabolite comes after metabolism. Now let us consider 3 medications mentioned here: phenobarbital, carbamazepine, and phenytoin. These are all anti-epileptics. These 3 medications are enzyme inducers. So if any of this enzyme inducer, it can be phenobarbital, it can be carbamazepine, or it can be phenytoin. If they are used with valproic acid, obviously since they are enzyme inducers, they will increase the metabolism of valproate. And if the metabolism of valproate increases, the concentration of 2-propyl 4-pentanoic acid will also increase. So that is not a favorable condition. So we should be very careful. In fact, we should avoid this kind of combinations. Phenobarbital with valproic acid or carbamazepine with valproic acid. Carbamazepine by itself is hepatotoxic as well. Phenytoin with valproic acid also. Another medication is there, that is rifampin. Rifampin is also a very powerful enzyme inducer. So rifampin can also cause the same problem. If rifampin is used with valproic acid, it will induce the metabolism of valproic acid, which will increase the formation of this hepatotoxic metabolite, leading to hepatotoxicity. So that's it with the short video that I thought to share with you. So here we have learned a lot of things: to remember the name of the drugs that cause hypokalemia, to remember the name of the drugs that cause hypercalcemia, then a significant drug interaction of valproic acid, some important features of carbonic anhydrase inhibitors, etc. So I hope this presentation has been productive for you. And if you want more presentations like this, because it takes a lot of effort to do this, then please do subscribe and share to maximum people. Because as I always tell you that knowledge is powered and knowledge shared is knowledge doubled. I'll be back with more interesting videos, more interesting episodes. I have a lot of plans in my mind. Just need to get the mindset and the timings correct. And please contact me in LinkedIn if you have any queries. Okay. So thank you so much for listening to me. See you until the next time. It's goodbye.